Good afternoon, everybody. My name is Anto Bonci, and I am the founder and president of GIA Healthcare in the United States and the scientific director and co-founder of Brain & Care in Europe. Today, we'll talk about how I ended up as a neurologist and as a neuroscientist to encounter TMS, transcranial magnetic stimulation. You know, this is a course where many of us will cover specific topics, and I'll just give you a brief journey over the next hour or so on how we went from basic preclinical trials and studies with optogenetics to creating ideas and protocols to use brain stimulation for cocaine use disorders initially, and then for addiction. So we're gonna start from that. And this is perhaps the most important slide for the many of you that will see this recording. You may have questions. Please do feel free at any time to email me, to contact me. This is my email right here, anto.bonci@giahealthcare.com. And Lindsay for sure will also share that with all of you, but please do not hesitate at any time to contact me, and I will answer any questions that unfortunately today, because of the recording, we won't have the opportunity to answer and share with you and the others. So this is Miami. We are now based in Miami, but all the work, the scientific work that I'm gonna show you initially was done at UCSF. It started at UCSF and it finished at the NIH, at the National Institute on Drug Abuse. So I'm very grateful for State of California funding and NIDA funding to be able to do those studies that led to the use of TMS in cocaine use disorders and addictions. As a disclosure, we chose not to have any intellectual properties filed. We want our science and our protocols, of course, to be shared freely with everybody. I'm not affiliated with any TMS companies as well. I am a co-owner, as I mentioned before, of a few clinics in the United States and in Europe. And this is, as you all know, a scientific presentation. It is not to be perceived as medical advice. So, first of all, before we get into addictions and science, we need to talk about something that has to do as well with addictions. And we have seen this with our patients over and over and over. This is a very old quote from Hippocrates, actually, and what he said, but is so true, even 2,500 years later, is that if you want to heal somebody, ask them if they're willing to let go, what makes them sick. And this is something that we in the clinic keep in mind every single day. No matter how many tools and technologies and therapies we can create, the participation and the commitment of patients, as you know, and we'll talk about this later more, is always crucial and fundamental. But quality of life has been affected very severely in an unprecedented way by COVID in these last few years. You all know what happened with the COVID pandemic. I don't need to dwell on that, but these are measures of quality of life. And as you can see, personal health, physical, mental, and spiritual is at the top, which is what we try to do when we use transcranial magnetic stimulation. And as you can notice, number 2, relationships, 3, education status, 4, work environment, 5, social status, wealth, 6, sense of security and safety, 7, freedom, and 8, autonomy in decision making, which has to do with TMS, are all correlated. And 2, 3, 4, 5, 6, and 7, and 8, they all influence, at the end of the day, physical, mental, and spiritual health. So everything that is listed here in one way or another for the majority of people in this planet was affected by the COVID pandemic. And if a human can be compared for a second to a watch, this is the most complicated watch ever created, actually, by Vacheron Constantin many years ago. If one of these pieces breaks, you know exactly what happens to us. The whole machinery gets into a lot of trouble. From a point of view of the COVID pandemic, and by the way, many of these symptoms that I've listed here happened both in people that had a COVID infection or in people that, because of the isolation of the pandemic, because of the emotional and social stress that the pandemic created, experienced. And the list goes from decreased concentration and mental focus, difficulty maintaining attention, memory impairment, increased fatigue, insomnia, anxiety, panic attacks, depression, anhedonia, lack of sense of pleasure, low motivation, increased stress, agitation. These were experienced by the majority of people because of the pandemic. As for us, there was a very significant increase in the percentage of people that, because of COVID, increased addictive behaviors. So this is a very important issue that has changed because of COVID. Now, as you may all remember, from a pure medical, biological point of view, COVID creates several different things. Autoimmune reactions, our immune system, right, is affected, increasing inflammation. There can be damage in small blood vessels, both in the heart or brain or lungs, for example, as you may know. COVID has been found actually in brains post-mortem of patients that didn't even have any symptoms whatsoever. That's another piece of information that we recently acquired. And also, according to this very beautiful study in the UK, on about 237,000 patients, about 1/3 of them who had a COVID infection experienced long COVID, meaning symptoms that were still present after 6 months post-infection. Now, how many of us, when we have a mental health problem, seek for help? It is estimated that about 50% of us, the other 50% will not, and we'll get into the reasons why. Also, 1 in 5 US adults live with a mental illness. That's a very big number, almost 60 million people, and it may be underestimated because this number comes from 2021. 1 in 5 US adults experience some mental illness every year, and 1 in 20, which is still 5% of US adults, experience a serious mental illness. So you can see what is the impact to their families, themselves, and society every year. But the reason is, why not more people seek for help? And statistics and the studies show that cost is the first reason why people in the US do not seek out for help. Thinking they could handle the problem without treatment, which has to do probably with lack of proper information. 26% of us, which is a very big number, not knowing where to go for services. Another quarter, basically 24%, not having time, 20%, and 10% they believe that treatment wouldn't help. So it's astonishing to see in 2023, with all the wealth of free information available, how many people do not know that there are other options. And this is really bringing us, guys, to TMS. The majority of people don't know that TMS does exist. And this is part of what we have to do as a community, to at least inform everyone that we are not stuck in the 60s or 70s with certain medications that do help a percentage of people, God bless for them, but that TMS is there. There is a lot of studies about it and can really help, especially in diseases where there is no medical treatment available. And my research, I started as a postdoctoral fellow at the Volume Institute in Portland, Oregon, an amazing institution. And then I moved as an assistant professor, and then over 12 years, full professor at UCSF in San Francisco. And I worked at the Ernest Gallo Clinical Research Center as well. And then the last 9 years of my research were done at the NIH in the intramural program at the Bayview Johns Hopkins campus in Baltimore. And I always targeted, as to what I was just saying before, orphan diseases. What I mean for orphan diseases are conditions, for example, cocaine use disorders and addiction, that do not have currently, beside therapy, which is wonderful, do not have currently a medication or any neurobiological treatment that is diffuse and standard. So my target was, or my research was cocaine for many, many years. And I would like to remind everybody that cocaine is still the second most abused drug in the planet. And once again, cocaine is on the rise. Cocaine and stimulants have never gone away, they're coming back and they're rising up again. It's only second to cannabis and cannabinoids. Another angle on why TMS is extremely important is that there are a lot of women during pregnancy that do take cocaine and other drugs. And as you know, pregnancy is a very delicate time for the fetus and the mother, where actually many medications cannot be safely used and taken. So it's almost, I don't know how many people know this piece of data, but between 5 and 30% of women, depending on the geography, actually are exposed to alcohol and other drugs during pregnancy. 30% is a very big number, only in certain geographical locations, but that's a very big number. And the top drugs are alcohol, ecstasy, methamphetamine, heroin, marijuana, and prescription drugs. So this is also where TMS can really help. And all the studies that we did started from clinical evidence. Clinical evidence based on functional imaging, studies done by Nora Volko, by Rita Goldstein, Hugh Garavan, Elliot Stein, and many others, showing that people that chronically used cocaine had a reduction in activity in certain parts of their frontal cortex. And as you know, the frontal cortex is our decision-making control center. The frontal cortex has been object of studies since 2,500 years ago, ancient Greek. Free will, decisions. Am I destined to live a certain life, or do I own my own decisions? The frontal cortex is, in my opinion, probably the most fascinating brain region we have. It's really the borderline of science, medicine, literature, and philosophy. And patients that have taken cocaine for a long time have a decreased activity of the frontal cortex in certain portions of it, and an increased reactivity of some other parts, for example, parts that will respond to cues that can trigger the research of the addiction, okay? And the idea that Billy Chen, the lead author in the study that we published in Nature many years ago, had, Billy, this phenomenal researcher, was that he wanted to see whether, first of all, we could model and replicate a decrease of activity in the frontal cortex in a rodent model. Why? Because we had this technology called optogenetics. And with optogenetics, which is a technology, I'm showing here just an image courtesy of Ed Boyden from MIT. Optogenetics was invented in 2004 by Carl Daxeroth at Stanford, Ed Boyden, Feng Zhang, and Ernest Bamberg. And the phenomenal power of this technology is that we can, with optogenetics, turn on or off entire clusters of brain cells that can be selected with promoters. And basically, in this case, we used the idea of applying optogenetics to our behavioral studies to see whether by turning on with optogenetics the frontal cortex of these rodents, we could basically restore normal brain activity and eliminate the interest in cocaine self-administration. So that was the logic of Billy creating the study that I will just tell you within the next few minutes. So the idea that Billy developed was to use a behavioral model that was previously developed by Pierre Di Piazza, Barry Everett, and David Belen, and a few others. And this is a behavioral model where rats had access to cocaine for a couple of months, and they need to press two levers, the seek lever and the take lever, and there are random intervals between them. And then, after those couple of months of the seek-take chain of lever pressing, rats were exposed to 4 sessions once a day of a mild negative consequence, food shock, mild food shock. And the idea to introduce a negative consequence was that we wanted to see whether all rats would still lever press when they have a negative consequence associated with cocaine. In other words, if they were really interested that much in taking cocaine despite the negative consequence or not. And what Billy observed was that the 70%, the majority of rats, stopped lever pressing. As you can see here, they thought twice. This is the interval latency to see. And the number of lever presses during those 4 sessions in pink with food shock decreased to basically 0, because 70% of these rats, they weren't interested enough, we are guessing, on cocaine to keep on lever pressing despite the negative consequence, the food shock. But the remaining 30% of rats, the compulsive shock-resistant rats, they kept on lever pressing despite food shock. So these shock-resistant compulsive rats became the main object of study after we did these initial behavioral evaluations. And Billy chose to do the electrophysiological recordings in the prelimbic cortex of the rodent's brain. The reason is that the prelimbic cortex, as you can see here, is very heavily connected with the anterior cingulate, with the infralimbic, with many other brain regions, including most of the limbic system, the dopamine cells, periaqueductal gray, dorsal raphe. So basically, this is a central hub in the frontal cortex of rats, the prelimbic cortex, that Billy considered the prime place to study and see whether this chronic exposure to cocaine changed activity, basically firing activity from these cells. So this slide shows what happened to these brain activity action potentials in the 3 groups of rats that were never exposed to cocaine, naive rats. This is actually staining of a neuron that was infected with chenorodopsin, so with the optogenetic technology, layer 5 of the prelimbic cortex. And as you can see here, the naive, never seen cocaine controls had a lot of evoked action potentials, a lot of brain activity. Now, the shock-sensitive guys, the guys that stopped self-administering cocaine when they were exposed to the food shock sessions, they had a reduction of action potentials, of evoked action potentials, but much stronger the effect was in the shock-resistant, the compulsive cocaine seekers. Here, the evoked action potentials were next to nothing. So the idea, and this is the summary of the data, but the idea at this point that Billy had was, okay, what if now with optogenetics we re-evoke action potentials and activity in the prelimbic cortex by stimulating the layer 5 cells? And I should mention that, as you can see in the methods of the articles, and guys, please feel free to ask me the articles at any time, he pre-injected all these rats with chenorodopsins, with this optogenetic technology, before the experiment started. So he didn't know a priori whether these rats would become shock resistant or shock sensitive. He just injected all of them so that after the behaviors were completed, he could go with the fiber optics and evoke these action potentials and brain activity. And the hypothesis is if hypoactivity of the prelimbic cortex is linked with this cocaine seeking self-administration, then stimulating with optogenetics, this frontal cortex, the prelimbic area, should reduce cocaine self-administration. As simple as that. So restoring normal firing activity of these cells, if this hypothesis has more than just correlation but causality, should restore normal brain activity and reduce cocaine self-administration. And the paradigm was then, after those 4 days of shock training, Billy turned on channel rhodopsin stimulation throughout the entire sit period of this lever pressing. And what Billy observed was that, first of all, when channel rhodopsins, meaning optogenetics, were functioning and action potentials were activated, rats would think much longer before they would lever press. The latency to press went way, way up. The lever press interval went up, and most importantly, when again we turned on the frontal cortex again of these rats, the number of lever presses went way down. So at least we knew now that when we restored brain activity, action potentials in this prelimbic cortex, rats for some reasons would stop self-administering cocaine or reduce it significantly. So this study that Billy and several of my postdoctoral students did over 5 years was a very long study, but again, it resulted in this beautiful Nature paper for Billy and our group. These results led to a lot of questions. Did we have a mechanism of action? No. We didn't know exactly what changed, why this reduction in activity of these prelimbic neurons. So what do you do next? You could pursue development of medications. Some people do. As many of you know, development of any medication, unless it's off the shelf, takes between 12 and 15 years. It's about 10 to 15 billion dollars to develop new medications from scratch. So that's a very long road that we didn't want to take. A beautiful technology that is very precise is deep brain stimulation, if we wanted to go to people and clinical studies and use precise brain stimulation with deep brain stimulation, but brain stimulation requires surgery. And as this technology is extremely helpful, for example, in patients with Parkinson's disease, we didn't feel that at the time was the best path for us to pursue. So we started looking toward TMS, transcranial magnetic stimulation, the reason why, guys, we are all here today. And if we go for a second, a little bit back in history, and I know that some other classes will cover the entire history of TMS, just for a second, I just want to mention that the concept of using electricity actually started in the medical field with the father of medicine, with Hippocrates. Hippocrates already knew 2,400 years ago that somehow using an electric fish would help patients with migraine. And he used to apply, back in the ancient Greek, this tiny electric fish into the forehead of patients to relieve pain from migraine. This is a very interesting study that evidence that if you think about it, how did he think so many years ago that something electrical was involved in pain and in our brain activity? That blows my mind. Then the Romans, with Scribonius Largus, the doctor, the physician of the Emperor Claudius, recycled the same idea of using this electric fish in patients with chronic pain and migraine, but then more organized science started in the Renaissance. In 1771, where Luigi Galvani in Italy started doing experiments with electricity in a more structured way, in a more scientific way, and to make it in another jump, in 1820, Hans Christian Ørsted discovered probably what is the most crucial piece of scientific evidence that led to the development of TMS. He discovered during a class with students that when he put this battery randomly next to a compass, he noticed that the compass would turn toward the electric field. That was the beginning of the idea that electric and magnetic fields are always present at the same time. So it started the idea of electromagnetism. And TMS, the machine, the first TMS magnet, was actually developed in 1985 by Dr. Anthony Barker. this very elegant gentleman here, when clinicians, the story says, were asking him to create something for patients struggling with depression. And depression was, and patients in general, as many of you know, 35 to 40% of patients do respond well to medications, but the remaining 60% either have too many side effects or they don't feel significantly better with medications. So the clinical community was asking physicists to develop something else, something more, with the idea, again, of stimulating the brain to relieve depression. And of course, the strongest evidence to support this idea came with subsequent functional imaging studies that I'm sure all of you know, where patients with depression have reduced activity shown with functional imaging compared to controls when they struggle with depression, right? So this is how the TMS made it into the clinic almost 38 years ago. A few things that probably all of you know at this point. TMS is non-invasive, obviously. It's like a AAA battery filling in your forehead for very small coils such as this one. It's been FDA approved for depression, anxious depression, OCD, and smoking cessation for a while. It was brought to the clinic in the mid-80s, and there are actually now more than 20,000 articles on TMS, so it has become a whole field of expertise of its own. And we were very fortunate to see Europe give the CE approval already in 2021 based on our studies and other studies for the use of TMS for substance use disorders and addictions. And many millions of people have used TMS at this point, so that's why we are all here and all very excited. We all know that TMS is not electroshock, and I don't need to convince this audience about that. You will also have a full lesson, I'm sure, on what are the main mechanisms of action of TMS, and those studies are keep on expanding and expanding. There is more and more, but the four main mechanisms of action, as far as we know today, we are at the end of 2023, are the chemical and metabolic, basically increasing dopamine release, several other chemicals during the TMS protocols. We have a vascular effect meaning that there is an increase in brain blood flow and oxygenation because of TMS in general. We have brain plasticity. Many studies from many different groups, from Bumizang and to many others, have shown that. And we have a very intriguing anti-inflammatory effect of TMS, reduction of certain molecules such as interleukins, effect on caspase-1 have been described, and so on and so forth. So the summation, as far as we know, of this pro-oxygenation, increase in brain blood flow, brain plasticity, anti-inflammatory, and chemical metabolic effect of TMS, as of now, seems to be the main reasons why TMS is so different in terms of therapeutic efficacy compared to traditional medications. You also know that TMS comes in two main flavors. There are protocols that excite brain regions, and there are protocols like the 1Hz protocol that reduces brain activity in general. So we can really use protocols in TMS in many, many different conditions. Something also very important to remember for what I am about to share is that even when people, this is a beautiful study by Michael Fox, Alvaro Pascal Leon at Harvard, even when people choose to stimulate the dorsolateral prefrontal cortex, for example, for depression, and those are the red areas that you can see here, different clinicians chose slightly different brain coordinates. In general, what you see is that there is an increase of metabolism with fMRI in a region, in parts of our brain, much larger than just the area of stimulation, much larger than that. You see the yellow areas and the orange are much wider than just the area of stimulation with TMS. So this is a network effect. It's never a very single specific effect in isolation, just on the dorsolateral PFC. And the first study that we did after we published the Nature paper was basically a pilot study with my Italian collaborators, Alberto Terraneo, Luigi Galimberti, Sonia Kindamo, and a few others, to try and see whether offering TMS to patients with severe cocaine addiction by stimulating this frontal region, and we chose the same dorsolateral prefrontal cortex that was chosen many, many years ago for depression, would change anything in terms of craving or cocaine or interest in cocaine in these patients. So the pilot study selected 32 patients. The average use of cocaine in the TMS group was 16.8 years of cocaine use, about, let me see, four times a week or more actually, on average. The control group had only 13 years of cocaine use, and these were all patients that were treatment seekers. Now, one feature about treatment seekers that many of you know is that treatment seekers are more prone to the placebo effect. So we kept that in mind in our pilot study. And the two arms of this study were as follow. The experimental group where TMS was given, but no medications, 16 patients, no serious side effects. 16 of 16 patients, 100% completed the study, and urine drug tests were negative in 11 out of 16 patients, 70%. In the control group that received medications, for example, benzos or whatever the patients needed, no serious side effects. 81% of the patients, 13 out of 16, completed the study, but cocaine negative urine drug test, only 3 patients out of 16. So a big difference in this pilot. Then we offered these patients to cross over to the TMS treatment, 4 weeks of TMS initially, 5 times a week for the first week, and then 2 times for week 2, 3, and 4. Very light, started easy. 7 out of 10 of these patients had urine drug test negative, even of the group that we recycled. So these results were very encouraging. They were saying that after 90 days, the majority of these patients had urine drug test negative after 4 weeks of cocaine, of TMS treatment for their cocaine. So many studies after this small pilot study were done also by other groups. And I just want to mention the study from the University of Florence, because as I mentioned before, treatment seekers, which were participants in our pilot study, tend to have a larger, stronger placebo effect. So this is a very interesting study from Guido Managlioni's group at the University of Florence, where he did a randomized double-blind study. And luckily for patients and science, he confirmed basically what we observed, that the TMS treatment had these patients with cocaine use disorders as the primary diagnosis. And as I mentioned, there are quite a few other studies at this point regarding that. But we as a team had to make a decision. And universities do beautiful clinical trials, as they have done since then, and they continue to do that, whether it's cocaine, opioids, alcohol use disorders, and that is what universities are for. These clinics of my collaborators and I decided a different approach, decided not to pursue the traditional clinical trials as universities were doing that and are doing that, but to allow every single patient, independent from how many co-diagnoses they had, cocaine use disorders plus alcoholism plus opioids use disorders. In other terms, we decided to accept every patient with any combination of diseases, whenever they were appropriate for TMS, and collect basically this very non-homogeneous cluster of patients. So it was a choice, and it allowed the entire team to really keep on understanding more and more and more what TMS can do. But over time, also, we extended the treatment beyond those initial 4 weeks, and because quite a few patients were coming back, basically, to do what is called maintenance. Now, I should mention that one of the things that we should do more, clinicians, even when they do not run clinical trials, is to publish somehow the evidence that is collected in the clinical practice, because it is not as rigorous, as beautifully designed as clinical trials, but it's still daily evidence that should be shared with all the caveats and limitations. So non-clinical trials, but it's still daily practice and very important clinical evidence that I think we should do. And we are trying to a better job in sharing as quickly as possible, because it can inform additional clinical trials in the future. So what we ended up doing was that after 1,000 patients collected over the years, skipping forward from the Terranium study in 2016, my team and my collaborators started to analyze all the data from these 1,000 patients to extrapolate additional information. And the information that we found was very interesting. Out of 985 patients treated with TMS, 284 were selected to try and have some homogeneity, right, in the patient population, which is always important. Urine drug test, self-report, and family corroboration were used to analyze this data. And this is a study by one of my clinical directors, Grazia Amadeo, in Italy. And this is probably the key study that McVenture used in Europe to obtain CE approval for the use of TMS for substance use disorders. What you see here is a comparison. The yellow line is the median, basically when 50% of the patients after doing TMS stimulation protocols relapsed. And on average, it took them 91 days. But what did we compare this population to? We didn't have an internal control. So we chose this beautiful data by Rajita Singh at Yale. And this was, we just called it, to keep it simple, treatment as usual. And Rajita's study showed that without TMS in their data, 50% of the patients with treatment as usual relapsed after 51 days. So there was already a pretty interesting difference between the two groups, even if they were not part, I repeat, of the same population of the same city. So we take this data with a grain of salt, very important. But the other part that we collected was how many patients after finishing the TMS treatment then came back for more TMS, and how many patients over time, these patients were followed at the end for 24 months, how many patients after that relapsed and wanted more TMS. And you see the yellow dots, these were relapses to cocaine use. Remember that these patients on average were using cocaine more than 4 times per week, and now you see a few dots here and there, particularly patient 41, for example, and so on, a few others. But this is not anymore after TMS 4 times a week, it's way, way less. And 7 patients came back spontaneously to get more TMS. Some patients came back because of the cocaine use before they relapsed. Some other patients came back right after they relapsed. Again, they felt empowered, some to prevent by searching for TMS before they started. So this slide perhaps is the most important. So as I mentioned before, patients before starting TMS were on average using cocaine more than 4 times per week. And the average of these 24 months of data that Grazia and collaborators have analyzed shows that now the number of relapses to cocaine use after TMS went to less than 1 per month. So basically 0.5-ish times per month on average from before TMS using cocaine more than 4 times per week. So the reduction of cocaine use is astonishing. But I also want to mention that a lot of patients, about 50% of them, continue to do a few TMS sessions 4 times per month, 3 times per month, 2 times per month, and so on, over time for up to 24 months, again, whenever the patient felt that they were not using anymore in this very compulsive way, but they felt from time to time still the urge or the interest in using cocaine. So we turn probably into a chronic disease, a chronic situation, but on average, less than 0.5 times per month is a very important achievement for the majority of people. So we were very, very pleased with this data. And I just want to summarize here what the majority of patients say after they do TMS when they came to us for cocaine use disorders. I have to mention that after cocaine, we saw a lot of patients with alcohol use disorders, pathological gambling, and we published a study as well on pathological gambling and quite a few others. So these are the most common phrases that, independent from education, interest, etc., patients reported. And this is the most common. I don't think about it anymore. I don't think about it, whether it's alcohol, whether it's cocaine, whether it's gambling. It's not in my mind all the time anymore. Why was I doing it? Again, we are stimulating the frontal cortex, the decision-making control center. Why was I doing it? So patients say, it seems stupid now that I did it. Again, regaining the ability to make their own decisions. I don't dream about it anymore. This is particularly about cocaine. They say, many of them, I don't dream about it anymore. Now we have thousands of patients that have been treated since then. I see friends drinking, using it in front of me. I see a sign of a bar. I see a slot machine. It doesn't touch me anymore. Not even when I go by my usual bar or my friends are snorting cocaine next to me somewhere. It doesn't affect me anymore. It doesn't move me anymore. So the cue-induced response that triggers a patient to want cocaine, alcohol, gambling is not as effective anymore. And Colleen Allen has done also studies on that and quite a few others to show how TMS does help with that. I don't remember the pleasure of it. We have heard this from patients using cocaine. So even that pleasure that was so crucial in driving them to seek cocaine, that memory is not anymore central to their day and life. Now, we have also seen something else in many of these patients, which has not necessarily to do with the reduction of craving or interest in cocaine or cues that evoke alcohol or cocaine use, but on the cognitive domain. These are just a few examples. So again, very anecdotal. This is not the majority of patients, but I just wanted to mention that to you. Like this person, for example, that came to our clinic just for anxiety and depression, not really for anything related to addictions, but did TMS for a while, said, now I am more than what I used to be. Now I sing like I've never done it before. I am more confident on stage. I'm not afraid of going on stage. So a person reported being more than what they used to be, for example, before anxiety. We had a patient who was an athlete and into sports seriously, professionally, and said, I run faster, I run longer. I can focus much better during the game and during practice. Can we measure that? We don't have measures. Again, this is the corner of anecdotes, but I find it very interesting. Composers, I was stuck on producing these songs for almost 2 years, and now in 3 weeks, I completed what I wanted to complete. So again, very interesting on the creativity domain. And by the way, there are studies on TMS and mental performance and physical performance as well. But again, these are just anecdotal that I find very interesting. Also, we go back to the decision-making part. I do TMS before my advisory board because it helps me make better decisions. So we go back to the central hub, the frontal cortex, the decision-making control center, the craving control center. Now, this is a topic for others, but do remember that TMS, as you know, has many applications, studies from Brown University, for example, suicidality reduction because of TMS. It has been studied a lot in adolescents, adults, elderly patients, whether it's anxiety, depression, or both. Data about trauma-related disorders, Alzheimer's, Parkinson's disease, PTSD, you name it. So TMS is literally exploding with data lately, and it's getting finally the attention that it does deserve. And in conclusion, for our lecture, we started from a very simple rodent study with optogenetics, and we ended up very quickly, within just a few months, to design those very simple clinical trials like our pilot study. But now evidence is mounting more and more that TMS can really help in many types of addictions beyond cocaine addiction. So I love this story because it's a beautiful demonstration that basic research does really matter, and we always need to keep on spreading that message, even if it's very frustrating at times to do basic research because it doesn't lead immediately to outcomes. I've done basic research for 25 years, and this study was probably in the short term the most immediate that got translated into clinical studies. But basic research matters. And TMS is this phenomenal technology that will gain, in my opinion, more and more and more traction because of the applications of TMS in a huge variety of neurological and psychiatric diseases is expanding basically as we speak. So in conclusion, our optogenetic study by Billy and the rest of the team was the first study that showed a scientific rationale on using TMS to treat symptoms of cocaine use disorders. Many studies for decades have actually shown that TMS can offer a higher success rate than quite a few medications. And my hope, and also where medications are not available, like cocaine addiction, for example, has no medication really to treat it. And my hope is that TMS will be, again, more and more available, not just in university or private clinical settings, but ideally in every hospital where everybody needs somehow TMS. Hopefully, this is going to happen sooner rather than later. Another very important point that I wish to emphasize, we don't want to overemphasize the role of TMS in treating, for example, cocaine use disorders. TMS always works best when there is therapy, whether it's whatever the patient needs, cognitive behavioral therapies, DBT, EMDR, you name it, whatever a patient needs, and medication management. I never want to have the message be just do TMS and everything is going to be fine, especially with addictions, which are very multifaceted, complex diseases. It's always the combination of the medical history, diagnosis, medication management, therapy, and TMS that leads the best results. So this is very important to emphasize, not to take anything away from TMS, but I don't want either to send the wrong message that now with TMS we're going to fix everything quickly, because TMS does its part, but it depends on a comprehensive plan and a program for every single patient. And finally, the number of TMS protocols and uses is expanding constantly, and I love this because you all know that side effects are very well known and very reasonable. And I still think that as of now, TMS is the most promising emerging treatment for a huge variety of substance use disorders and neurological psychiatric conditions. Hopefully, technology and medications, new medications will show up in the near future. But for now, I think that there is still a lot of room to expand for the uses and applications of TMS in the whole domain of neuropsychiatry. So thank you all for your attentions. You have my email, and if you have any questions, I'm going to conclude. I'm sorry to thank people, but please do not hesitate to email me and to contact me. A huge thanks to Kaldasarov for optogenetics, of course, Billy Chen, the lead author of the Nature paper. This is the RTMS research team that I mentioned before, and my current team in the clinics. And I hope to hear from you guys, and please shoot any questions you like. Thank you very much.